And a couple of papers I thought were pretty fascinating in the past 5 years or so, mediating potential recovery post a perinatal brain injury. And then build upon the theme of inflammation, again, because I think our babies are born in this environment. So review the evidence associating early systemic inflammation with white matter injury, and then explain the rationale behind the importance of nutrition in modulating this systemic inflammation. Hopefully what we'll touch upon and that I can convince you is that early nutritional management is intricately involved in short-term morbidities and long-term outcomes, that changes to current strategies are essential, as we've been discussing this weekend, and that longitudinal nutritional care is also important in neurodevelopmental outcomes of our premature infants, so even beyond the NICU and after they go home. So we'll begin with the postnatal growth of the premature infant. So you've seen this. We're going to discuss nutritional support, how that helps with extrauterine growth, or how it's related to extrauterine growth, especially head circumference and brain development, and what that does to outcomes. That's primarily sort of an energy-driven discussion, and then how it may directly do so in lieu of the necessary effects on this, and that's more through the immunomodulatory effects of nutrition. Well, we're all aware that during this period, and as I showed you with the lipid data, that our babies miss a lot of that last trimester. And during a period where there's tremendous fetal growth and establishment of those nutritional stores. And we discussed the intestinal development, how it undergoes rapid growth and differentiation, and how amniotic fluid is a major trophic factor. But they missed this with the abrupt cessation, never really established those nutritional stores to build them through, reliant on us. And I think we're continuing to learn how we may have to replace some of these nutrients. So often we don't do anything, or maybe not enough during that early period. So you've seen this curve several times, but I do think it's worth looking at it again. This was in 1999, Dr. Ehrenkrantz's data. And he shows here with these growth curves, 50th percentile, that although most of our babies, even though I will highlight that there are a fair number that are more growth restricted than, you look at the standard population. But here you see that many of them will plot along the 50th percentile. They'll go through their nadir of growth in about 2 weeks and then restart to gain weight. But that trajectory never quite matches what their birth trajectory was, and as a result, in the end, do not grow very well. Here's 2003. Journal of Perinatology, Dr. Clark, he looked at across gestational age, weight gain in grams per day. And in yellow was what they observed. And in gray is sort of what would be the estimated daily fetal weight gain. So you can see along time and at each gestational age, the approximation to what we expect these babies to gain is never quite achieved. I've discussed the LGAN data already. And this is just a review that you'll have now online about what the LGAN data is all about. So I looked at how we were growing in this cohort that's now 2009. So 10 years later from when Dr. Ehrenkrantz's data was observed. So what this graph shows is these are z-scores, so standard deviations, each standard deviation below the 50th or above the 50th percentile, the median. Along the x-axis is the z-score at birth, and along the y is at 28 days. If you were at least maintaining your birth growth percentile, you should be tracking along that red line. So anything above means you're exceeding, you're doing really well, you're above your birth percentile. Everything below means you're dropping, you're losing weight, you're coming off your growth curve. And you can see that many of our kids land underneath that line, that red line. So that even though at birth 18% of our cohort had a birth weight z-score below 1, at 28 days, that was 75% of our cohort had a birth weight z-score below 1. So even And what was interesting is that not exclusively 100%, but most of the nutritional goals that you hear about, what growth velocity do you want to achieve? What kind of lipids or grams per kilo per day or proteins, grams per kilo per day? Many of those were actually achieved in this 2009 cohort. But despite that, we were still seeing this high prevalence of extrauterine growth restriction. So again, perhaps a reevaluation of what our goals should be. And this extends even after going home. This was early data by Maureen Hack. And what you see here is the percent below the third percentile. So this is height on top, weight on the bottom, birth, 40 weeks or term, 8 months, 20 months, 8 years. And this is your control group. So you can see over time at birth, let's just concentrate on the weight, about 20% were below the third percentile. So matches a little bit about what we were saying before, that there might be something inherent about premature delivery and compromised the fetus in that perinatal period that may have precipitated this delivery. So more of them are growth restricted at birth, but then about 55% at term. This does improve over time and by 8 years of age, but never really comes to approximate that of their term controls. So it persists after discharge. And this was one of the graphics in Dr. Ehrenkrantz's recent paper in 2011 that Dr. New showed. Dr. New showed more of the data. Here I liked the principle, and this is how they looked at the data. They wanted to know, well, that critical illness in the first few weeks of life, how is that related to later growth and outcomes? So again, concentrating in that early period. To look at that, they broke up their analyses. They said, well, let's look at this, and how is that related to this? And is this related to this? And what they did show was that, yes, the effect on this adverse outcomes was mediated by early energy intake in that first 7 days. So I kind of find that quite humbling that within a week of these babies in your care, you have this impact in their long-term neurodevelopmental outcome out to 2 years or more. This is also his data showing the importance of that growth and the growth velocity. This preceded the previous paper I showed. We're looking at growth velocity, 12 grams per kilo per day. He divided it in quartiles, 16, 18, greater than 20, and the percent with these outcomes. So you can see the lower your growth velocity, the higher likelihood you'll have cerebral palsy or a mental or motor developmental index less than 70, which is less than 2 standard deviations before, 1 standard deviation below the norm, or 2. So how is this related to growth in other ways? And other people have shown. So here, head circumference at 2 years associated with your neurodevelopmental impairment. And it sounds obvious, but I think it's important to, and I'm glad they did it, to associate these outcomes and these overall growth. Microcephaly at 2 years of age, microcephaly or you're not. What's the likelihood of developing cerebral palsy, severe cognitive or motor delay? And they showed that association with microcephaly. They went on, it must be in another paper that I'll come up to. We've talked about how this early neonatal nutrition or nutrition in adult health, and these are just some references, again, you'll have in your slide to look at, but the association with coronary heart disease, blood pressure, type 2 diabetes, and obesity. I think it's maybe important to think about it, but I agree with the sentiments that were discussed earlier. I think the neurodevelopmental impairments are paramount in our infants, and I think these associations may be specifically associated with specific types of infants and babies. So I do still prioritize the growth in the early neonatal period. So there is a high rate of extrauterine growth. This is still true over time, so I showed you 1999 to 2009. Even with incremental improvements in nutritional delivery and growth rates and attainment are important for long-term health. So I don't have the answers to these questions. What is the appropriate growth curve for a preterm infant? What are the limitations of using the intrauterine standards? What is the appropriate catch-up growth? What are the appropriate measures of nutritional attainment? I think we're still using very crude measures in weight and length. There's probably other measures that we should be able to evaluate at the bedside so that we can know earlier if our nutritional changes and modifications are having an effect before waiting till 2-year outcomes. And what are the nutritional strategies to provide that optimal nutrition and health? So showed how that energy intake, that early nutrition, growth velocity, supports extrauterine growth, head circumference development, and brain development associated with outcomes. What I want to talk about now, making this link to here, why some of the other elements of nutrition will be important because of this concept of ongoing systemic inflammation. So I'm going to step back a little bit and describe the environment in which these babies are often born. So maternal and fetal inflammatory responses. So chorioamnionitis. So clinically, there's some debate in the literature, how you can characterize, but clinically, our obstetricians use fever, leukocytosis, maternal tachycardia, maybe fetal tachycardia, uterine tenderness, a foul odor. These symptoms in this literature review here, 50% of our preterm infants less than 30 weeks were born in this clinical environment. Histologically, though, of those, it was only present in about 60% of the cases. So I just want you to appreciate that, yes, we probably clinically overdiagnose it, but pathologically, it's still a fair amount of babies. And that pathological diagnosis is the preferred definition in the literature for a maternal inflammatory response. So here you just see on panel A, a nice a placenta, no discoloration, and then in B where you have that sort of yellowish hue to it and yellowing of the umbilical cord. Histologically, what's going on, and I'll show you some cord slides, is that you'll have this inflammatory response along the chorion and the decidua and the amnion, and then that also, when it starts to involve the umbilical cord, we call that a funicitis, where the inflammatory infiltrate is now starting to wrap around the cord and the vessels and the veins and the arteries. So this would be a picture of the funicitis, where you can see this rim of inflammatory infiltrate around the umbilical cord vessels. There's many ways in which infection can be entered into the intrauterine cavity. You can have invasion via the fallopian tubes, an amniocentesis or chorionic villus sampling. You can have a hematogenous spread through the placenta, or you can have an ascending inoculation of bacteria that way. And it's really what I'm about to say is when the baby, so that's the maternal inflammatory response, when the baby starts to have the inflammatory response, we call that the fetal inflammatory response. So what's the consequences? Well, this intrauterine infection or maternal chorioamnionitis has been associated or linked to preterm delivery, which we know is linked to white matter injury and cerebral palsy, but it's also been linked to this concept of the fetal inflammatory response, where they define that as these elevations and these inflammatory biomarkers. That has been associated both with preterm birth and white matter injury. And I'll show you some of that data. But again, what I want to impress is it's not that acute event that then causes a delivery. And then the baby's removed from that environment. Those processes have started and are now in the baby. And the baby, I've discussed, has sort of this immature inflammatory response, immature innate immune response that then continues to propagate this. And then what do our practices, nutritional practices, do to continue to propagate this? So the persistent, Alan Levinson with the LGAN data showed that there's a persistence of this relationship between umbilical cord inflammation an elevated blood concentration of inflammatory proteins on postnatal day 7. So I had mentioned that we have the histology of all these placentas. So he has shown that link between that phenocitis and even out to day 7, that these markers of inflammatory proteins are still elevated. So there's a loop of sustained systemic inflammation. And this choreo and multiple studies have been shown to be associated with cerebral palsy or cystic periventricular leukomalacia. This is a meta-analysis that was in JAMA in the year 2000, showing that with the clinical diagnoses in premature infants, you see a 2-fold or a 3-fold risk in your risk of cerebral palsy or cystic periventricular leukomalacia. Histologically, those associations persist, especially with PVL, and then altogether, cumulatively, a 1.8 or almost 2-fold risk. Interestingly, the same does hold true for the term and the late term infant, which I won't talk much about. Lots of data, but 2 recent studies I wanted you to be aware of that just came out, and they're still in press, but they both show that this early elevated levels of blood biomarkers in the first early postnatal period, in the first couple of weeks, are associated with poor neurodevelopment at 2 years of age. So this is Mike O'Shea, where he's looked at these inflammatory markers, and you can see that both for the mental and the motor scale, you'll see elevations in IL-6, TNF-alpha, let's see what else, CRP, SAA. The one thing every time I look at this data, the other thing I wanted to share and discuss with you is that it's the same markers. So either we're looking at all the same panels and it's the same elevations, and we haven't gone outside to look at other biomarkers that might be uniquely associated with specific diseases. I think the other possible thing to consider is that all of these things are sort of culminating in a unified terminal pathway of inflammatory response. So again, maybe it's not an accident that we keep seeing the same markers over and over again in our babies. This is from the NICHD data and Wally Carlo. They did the same thing. They looked at cytokines. They didn't look as many, but they looked at similar ones and overlapping ones. And they showed that this early neonatal period, there was a persistent elevation in IL-8 in those infants that went on to develop cerebral palsy. So what can we do? And this is an open-ended question. What can we do to help mitigate some of those responses? This is just to show that it's not just a conceptual leap, that systemic inflammatory biomarkers or the presence of biomarkers can cause neuronal injury. Here in this study, they are able to isolate and demonstrate that cytokines are in fact neurotoxic and they inhibit oligodendrocytes. So what other evidence do we have outside even of the neonatal literature about persistent or chronic inflammation and brain injury? There's a few case reports that have been interesting. Infants who died of white matter injury had evidence on autopsy of still elevations of pro-inflammatory cytokines in the brain weeks after the initial perinatal event, so well after that. Another acute biomarker is found on pathology with infants with developmental delay or cerebral palsy. Also with autism, evidence on autopsy that there's an active inflammatory process occurring in the brain. And in the animal model, active markers of inflammation persist in the blood, in the brain, weeks after the induced injury. So there has to be an appropriate inflammatory stop. There has to be a way that the baby can say, okay, this is too much, let's bring in the markers, the mediators we have to stop this inflammation. This is what I think is so interesting about the fatty acid data. I told you how they're really important in resolvins, and resolvins is that stop to that inflammatory reaction, the brakes on the system. But they don't have the substrates to be able to produce the resolvins to put the brakes on the system. Either that or the cells are anergic to the response of that output. And I think that's where a lot of this research needs to go. So we have to change our concept from a static process where, and this is an evolution in my thought too, where I thought, okay, perinatal injury, the brain injury happened, and it's static and you kind of move on. Well, no, it's not a static process. It's actually an ongoing process. So it's not necessarily a single hit, but maybe a continuous exposure. Therefore, there's a period of rapid postnatal brain development, as you've seen from the images in the preterm infants. And since it's not a static event of what's happening, but rather an evolving process, that perhaps we can influence not only what's happening now, but what's going to happen. So there's a window of therapeutic opportunity. Well, we broaden our approach in managing white matter injury, targeting not only the symptoms, but the underlying pathogenetic mechanism. So in this window of opportunity, what are some of those nutritional strategies that can be put in place? So let's look at brain development and then the nutritional studies after perinatal brain injury and what did they find. So I showed you this already, and this is what I wanted to follow, that microcephaly correlates with the brain volume. Again, seems obvious, but I think it's nice to establish as a foundation. We're not making a leap, we're showing it. Decreased brain volume, decreased head size. Especially in these motor structures, deep nuclear gray matter. You've seen this figure too, where early parenteral amino acids are associated with head circumference. So even though early versus late amino acid delivery comes together at about a little bit after a week, just that difference in that early period made a difference in the head circumference achieved in the infants, with the males showing a greater signal than the females. So what few studies do we have at targeting some of these issues? How about improving head growth in the very preterm infant? This was a study by Tan, published in 2008, 142 infants, less than 29 weeks gestation, and they continued one of these two strategies until they were at least 34 weeks postmenstrual age. Energy delivery, these are the two strategies, 117 versus the standard of 93. The dextrose difference you see there, protein at 4 versus 3, fat at 4 versus 3. So interesting, there was no difference between the groups in the head circumference at 36 weeks postmenstrual age. But I think the failure of this tells us a lot. It was underpowered. There was actually less microcephaly that they had seen in the control population before. So improved nutrition during that period of time actually affected the study moving forward. However, even with this high hyperalimented approach to energy stratification, there was still a large percent in protein or energy deficit, 80% and 98%. So impressing upon me that, even when we, to use the word aggressive, but even when we aggressively try to move forward, you're still maybe not meeting all the needs. So what they were able to do is they were able to say, well, let's just graph that out then. Let's look at positive protein energy balance against the head circumference scores. And you can see that, or standard deviation of the head circumference scores, and you can see that, yes, in fact, your energy and your protein balance are very much related to your head circumference size. So they couldn't show the difference between the two groups because they didn't have as many microcephalies before. They had improved nutrition in both groups, but even with that improved, more aggressive nutrition, they still had energy failure. So when looking at energy failure alone, they see that there's a difference in head circumference growth. This is Isaacs, who looked at, this is also discussed before, the Lucas study, and the differences in that early nutritional intake that they did during the newborn period. Now they're looking at these kids at 16 years of age. And they were able to see a difference in, especially in the males, of caudate volumes positively associated with verbal IQ. So what about... So we know now that the nutritional management makes a difference in head circumference and neurodevelopment. But what about after the brain injury? What's been done there? And so there's been two studies that I'm aware of. There might be more, but these two caught my eye a few years ago. And that is, well, what can we do from term to leaving the NICU and beyond, the post-discharge care? So this study by Dabadine was in pediatrics in 2008. So they looked at infants with encephalopathy or white matter injury. And they randomized them, controlling for gestational age, gender, brain lesion. And they had one group do 100% energy, the other group, the average of what they considered 100% energy. So a little bit more energy and then what you would expect in the other group. They kept that diet from term to 12 months of age. They had 16 enrolled and they actually stopped early because of what they were seeing in their effects here. This is the corrected age over time, head circumference Z-score. First thing is, yes, actually, they all start to lose a bit of head circumference Z-score. But the group that was in the high energy did show that decline, but after 6 months to 12 months started to show an increase in their head circumference. What they considered in their average energy group continued to show that progressive decline over time. What was great is they were actually able to follow the families that were not consented. Either they just couldn't get to them or the family had refused, and it was a substantial decline in their head circumference. So even after injury, putting in place some dietary changes, you can make a difference among what they're receiving and what they are achieving for their final head circumference. This is another very interesting one. They followed through this, Dabadine followed through by looking at transcranial magnetic stimulation. So they were using that as an estimation of cortical spinal tract growth. So they look at, basically, they look at twitching of muscles with stimulations to the brain, single pulse stimulations to the brain. And then from that speed of that transmission, they can estimate the size or the axonal diameter of the cortical spinal tract. For comparison, they know, sort of what that size is on actual visualization of the cortical spinal tract. But then they took these three groups and they measured what that cortical spinal or that estimated diameter was based on TMS. And you can see that the high energy group was approximating what was considered normal values for that infant over time. Average was not, and then I'm not quite sure why they would have a no consent because they're not allowed to do anything to that baby. But anyway, so so you can not only, so the head circumference is improved, but actually the brain neuronal, the axonal tracts, they're improved with the nutritional delivery that you're providing. So growth failure, especially head circumference and even in the deeper brain structures, may not be inevitable due to the disease process, but rather maybe it's in part potentially reversible. So early systemic inflammation is associated with white matter injury and CP. The pathogenesis of white matter injury is chronic, not just a one-hit phenomenon. And since brain development is ongoing through at least early childhood, there are nutritional strategies that we can put in place along this continuum of this process. So we've spent a lot of time on the early period, the early initiation of parental nutrition and enteral nutrition and the nutrients that you're providing, but really following that out and even post-discharge for our infants, especially after having some perinatal injury, that these strategies might in fact be helpful at that point as well. So this is sort of how everything, and I'm happy to take questions, but how everything is starting to be put into place. So we've discussed the nutritional supports as an energy source mainly, supporting somatic growth, and that's related to outcomes. We've been talking, many of us, about immunonutrients. I had focused on the lipids and DHA being immunomodulatory. That important not only for growth, but for the systemic inflammatory response that I hope I've given you plenty of evidence that exists, and it's something we have to pay attention to. And hopefully through nutritional strategies, I think, you know, there's plenty of cases in the literature where you try to block one inflammatory protein, like a TNF alpha blocker or something. That doesn't go over very well, because, you know, one thing we also have to, I think, be humble about is what's good for one system is not necessarily good for another. And if you're blocking one protein for one system or one disease of interest, that might actually be integral for another process. So I'm not sure we're ready to go down that pathway, but I think if we're using nutrients or evaluating what the baby would otherwise be exposed to in utero, we can at least start to approximate that with hopefully even safer outcomes. And then how this chronic inflammation is throughout, and that intestinal development early on can be helpful in either mitigating it or propagating it, depending which way we want to go clinically. So thank you very much. Questions? Yes.
Thank you very much for this very interesting lecture. I would like to ask you whether the maternal nutrition, the mother who has chorioamnionitis, besides receiving antibiotics, whether her nutrition could actually influence in a way the fetal inflammatory response syndrome.
Right. You know, I don't think, or I'm not aware of any studies extending that back or to even start to discuss that. I think it's obviously worth evaluating and looking at. As much as we can optimize on the maternal end is only going to help us. But I'm not aware of any data that shows how it modulates chorio or the risk of, or how the babies do after that setting based on maternal nutrition. And anyone else is willing to pipe in if they happen to know.
Do you think that it could help, or is not possible?
No, I think it could help, because I think if you believe in the concept of that immunomodulation through nutrition, that begins with the mom. So I think if I'm going to be true to that concept, I have to be true through it, you know, all the way through. And I do think we have enough evidence where maternal health is important in fetal health that I would suspect that that is true as well. We just have to figure out how to study it, and we know and advise, so we know how to advise or optimize maternal nutrition.
Dr. Martin, thank you very much. But I have some questions.
Good.
What's the best growth velocity after birth? How we can calculate the growth velocity until 28 day, until discharge, from birth, from the third day?
You know, I think that's a good question, and maybe we even have to start fine-tuning that a little bit, and have what's your expected growth velocity at different periods of the NICU course. For this, most studies either do two things. They start at day 7 to 28 or 36, you know, weeks corrected age, whatever time period of growth that they're interested in, because they don't want to sort of negatively associate that drop in weight that they all experience.
From day 7, not from day 3.
Yeah, so so I'll get back to that. Thank you. Let me just, and then the second possibility is from the day you regain birth weight to then out to whatever endpoint or interval that you're trying to study. Why day 3? Only because most babies by day 3 haven't regained weight. And so that's mainly, so again, you don't want to negatively influence what that postnatal weight loss drop is on overall growth velocity. Is that a true measure of what you're providing nutritionally? You know, by day 3 when they're still losing weight and you're still, you know, working up on enteral. So it's those kind of considerations from a research perspective. But we've also talked about and heard that, you know, weight loss in that early period may not necessarily be a bad thing either. I mean, that might be the process, that postnatal adaptation that needs to happen. So maybe you look at that as a separate time point, and then from the moment they regain birth weight, or at a period where you think you're accurately reflecting your nutritional intake, and then calculating growth velocity from there on. Growth velocity is good to measure. I think it guides you. I think also, you know, we do rely on our growth curves, because, you know, I showed you in the other paper that even when most of our kids were achieving what you thought was a good growth velocity, you know, 18, 20 grams per kilo per day, You know, they still, yeah. So, you know, what's the optimal growth velocity? And maybe again, it's a collective measure, it's not just a single one. And so we'll plot on the curve, and if they're not growing or we're not satisfied, we'll continue to push their growth and nutrition. So we just switched to the Fenton growth curve, only because we thought it had a nice representative group even in the lowest of the gestational ages. They also had it by male and female, and so we thought it just offered a greater representation perhaps of what's happening now for standards. I agree with the earlier sentiment, though. I mean, obviously there's a lot of ethnicity and cultural differences and growth attainment, and you know, if everyone could afford to have their own growth curve, that would probably be the best.
I want to be sure that I have understood. When you speak of high energy, we speak about aggressive nutrition in preterm. So high, of
That's
course,
why
early TPN, high lipid, high amino acid. It's correct.
That is correct. That's why I pause a little bit with the aggressive, because I guess it depends where you start from, and anything higher than what you're starting from, you're thinking it's aggressive, right?
Okay.
So that's the only reason I was like, So yes, is it defined to an optimal what that total energy intake and protein and lipids? No, on the higher end, if not pushing a little bit more of what's standard, is what a lot of these studies did.
Okay. My second question is about what we have to do after discharge of these preterm newborns. When they are breastfed, because in Italy, fortifier are present only in the hospital. And if these preterm newborns are formula fed, what do you think about the so-called post-discharge formula that has more caloric than normal preterm formulas?
Right. Okay, so lots of interesting things about how to handle post-NICU formulas. So, pausing only because it's not easy, but let me try to get to it all. So the breastfeeding, the solely breastfeeding infant, if we feel like they still need the extra calories, we'll have the mom, we'll just figure out the mom can directly breastfeed for some feedings of the day, and then others we're supplementing the express breast milk, and she's providing it in that way. We're relying a lot, and I want to get back to us, on the pediatrician to obviously help us in the follow-up, which I think is, can be a challenge. So that was that. The transitional care formulas, there seems to be some incremental benefit. I wish I'd see, would see more. I think what we're seeing is, a gain of 1 centimeter or something like that. And so what we do as a unit is we don't necessarily say we have to do that for every baby who leaves the NICU. I know some units do. I'm not sure, we might still be in the minority in that. But we do reserve it for infants who are growth restricted or at the time of discharge from the NICU are less than the 10th percentile. But the practice is all over, and how much of an incremental benefit you get, I guess 1 centimeter is worth it. Was there another one? And then to optimize, and these studies really highlighted it, and that is, it's just really hard to get that kind of nutrition maybe in these infants in the post-NICU. And then I did follow-up for a while, infant follow-up, and we would see exactly what I showed you with HACS data, is that everyone is just growing, below the third, and they're growing, but they're not really achieving or crossing percentiles or getting to where you think you might want them to be. And so to coordinate those kind of efforts for the family to make sure their dietary intakes meet the sort of energy levels, and the pediatrician's on board, and it's a lot of coordination. It's probably a whole program in of itself to make sure that occurs. All right, thanks.